Welcome to AOTA's Continuing Education course, the new Occupational Therapy Evaluation Reevaluation Codes, Language and Components. AOTA is committed to bringing you the best in professional development content created by top-notch experts within the field. Our presenters today are Christina Metzler and Brennan. Christina Metzler is the Chief Public Affairs Officer for AOTA. In this position, she directs the federal, state, and regulatory policy departments. She has been at AOTA for 21 years and has worked for national associations in Washington in healthcare, disability policy, and long-term services issues for 30 years. Brennan, an occupational therapy consultant to therapists, healthcare facilities, private and public insurers. She has coordinated the Minnesota Occupational Therapy Association's peer review for 30 years, and in that capacity has reviewed thousands of therapy records. Her specialty is documentation and coding. She has had numerous articles on documentation published in OT practice. She has spoken at both AOTA Specialty Documentation conferences. At this point, I'd like to turn things over to our presenters to begin. And Christina, I'll turn things over to you.
Hello, welcome to the AOTA presentation on the new Occupational Therapy Evaluation and Reevaluation Codes. The learning objectives for this course will allow attendees to discuss how CPT describes the Occupational Therapy Evaluation and Reevaluation Codes, identify the components of the new OT evaluation codes, and select the appropriate code to reflect the level of complexity of the evaluation performed. New evaluation codes. On January 1st, 2017, new codes will go into effect for occupational therapy evaluations. The American Medical Association Common Procedural Terminology 2017 manual will list 3 levels of occupational therapy evaluation and 1 level of reevaluation under the Physical Medicine and Rehabilitation section, PM&R, the 97,000 series of the manual. AOTA participated in development of the language of the codes for over 4 years. We were successful in maintaining separate codes for only occupational therapy evaluations and no other professions. New codes substitute for the current evaluation and reevaluation codes. As I said, there are 3 new evaluation codes and 1 new reevaluation codes. CPT codes, as I am sure you know, is a set of codes, descriptions, and guidelines intended to describe procedures and services performed by physicians and other healthcare professionals. The OT evaluation codes. Formerly, 97003 was the only OT evaluation code. The new codes introduce a new concept that there are different levels of evaluations: a low complexity level, a moderate complexity level, and a high complexity level. Those numbers follow in sequence: 97165, 97166, 97167. The former OT reevaluation code, 97004, is now 97168, the new OT reevaluation code. The language in the codes is very important. The specific words that are used provide information on how you should approach an evaluation and what components are necessary. Because of our work with the AMA, the language in the CPT manual follows the Occupational Therapy Practice Framework domain and process. This is a significant victory. Evaluation as holistic. It follows the framework in this important concept and the components of this concept of a holistic evaluation. All components of an evaluation are interrelated. The clinical decision-making transcends the process and is interwoven throughout the process. Assessment is affected by the occupational profile and the medical history. And the plan of care incorporates all. Reporting the correct code is critical. We'll speak later about the issues related to payment in Medicare. But irrespective of those payment issues, you must report the correct code. A correct code is required by payers to assure that you are reporting and being asked to be paid for the service that you actually provided. It's required by the ethics of the profession that you indicate in your documentation as well as in your billing the exact or as close to the exact service that you provide as possible. Furthermore, providing the right code will help us to collect valuable data that we can use to develop changes in the future to the codes as well as to practice. New codes promote OT because it is based on the framework and includes an expansive look at the full scope of practice of occupational therapy. The new codes set the stage for promoting optimal occupational therapy as reflected in the framework. They require an occupational profile, they require assessments, standardized and other, and they describe the full scope of occupational therapy. Correct coding that you do in your daily practice promotes distinct value. As I mentioned, understanding the CPT language is important. The CPT says that occupational therapy evaluations have an occupational profile, a history, assessment, development of plan of care, and they emphasize the clinical reasoning and interpretation of the data by the therapist. In the evaluation, coordination, consideration, and collaboration with others, including the patient and the family, is important. The needs of the patient, family, and other caregivers are specifically referenced in the CPT language. In the evaluation introductory language, CPT identifies 4 components of the evaluation process: the occupational profile, client history, both medical and therapy, assessments of occupational performance, clinical decision-making, and the development of the plan of care. I will turn it over to Kathy Brennan now to provide the therapist's view of these codes.
As Chris was saying, there are 4 components in determining the evaluation level. However, only 3 of those 4 components are used to determine the evaluation level because those components have specific criteria attached to them. The plan of care is still very much a part of the evaluation process and the clinical decision-making necessary to determine interventions and client goals. But for now, we will be looking at the components of the occupational profile and history, the assessment of occupational performance, the identification of deficits, and also the clinical decision-making. The therapist needs to consider how complex or broad the occupational therapy profile and the medical and therapy history must be. How many performance deficits will be addressed? Which standardized or non-standardized assessments shall be given? The degree of clinical decision-making used. As Chris was saying, evaluation is a process. It's not a sequence. The evaluation level is determined after the completion of the evaluation. Therapists need to be familiar with all the evaluation components and consider the appropriate level as they proceed to the evaluation session. We thought it would be helpful to use 3 clinical vignettes as we proceed to identify the criteria in each required component. We used the same treatment diagnosis, but added increasingly more complex factors to show how these affected the decision to choose from low, moderate, and high complexity. I will read these 3 vignettes now, and we will come back to them as we proceed to learn about the components. Our first client is a 76-year-old female referred after a right distal radius fracture due to treadmill mishap. She lives alone in the community. She volunteers at the hospital's pediatric unit 3 times a week. She wants to perform daily activities, especially dressing. In her history, she has no prior medical conditions. Our next client in the moderate level is a 76-year-old female also with the diagnosis of right distal radius fracture that occurred at a barbecue when she tripped over her friend's dog. In her profile, we find out that she lives with her partner in a retirement community. She participates in social activities. She wants to perform daily activities such as toileting and dressing, and she wants to prevent another fall. Her history shows that she has diabetes and related macular degeneration. She received OT prior for low vision treatment. In our example of the high complexity, again, we have a 76-year-old female referred after a right distal radius fracture in the middle of the night while wandering. In her profile, we find out that she is a long-term care resident, previously mobile with a walker, toileted herself, engaged in art group, but admits to being forgetful. She has been isolating herself in her bedroom after this fall. She wants to be toilet trained, she wants to be safe, she wants to use her walker, and she very much wants to get back to her art group. Her history is that she has early-stage dementia, history of TIAs, congestive heart failure, prior rehab for stroke, ending with limited left arm function. So we will progress now to the next slide, but we will come back to these scenarios to help us determine the levels. Each component has to be separately determined as low, moderate, or high. Each component must meet or exceed the complexity requirement to appropriately qualify at that level of evaluation. The higher code cannot be used unless all 3 components, history and profile and assessment and clinical decision-making, meet the higher level. Here is a visual to show what I have been saying. In this example, the occupational profile and history has been rated at a high complexity level as there was a need for an extensive review of the client's history. The assessment of performance and identification of deficits is rated low. Clinical decision-making is moderate. The moderate and higher level complexity evaluation codes cannot be chosen as all the components do not meet that level. So you are looking at a low-level code example where the profile was high and clinical decision-making was moderate, but you need to choose the low-level code because the assessment was low. In this next example of a moderate level code, we have 2 of the components that are rated high complexity, but the assessment is rated as moderate. In this case, the moderate evaluation code is chosen despite the fact that 2 out of the 3 components are rated as high. Our third example is a high-level code. In this example, the profile and history, the assessments of the deficits, and the clinical decision-making are all high complexity. Therefore, the therapist would choose the high complexity code to bill. So let's talk about the criteria for each of the three areas and components that we are looking at to make our final decision on which code we will bill. The low complexity in the description of occupational profile and medical background and history states, an occupational profile and medical history, which must be done. It includes a brief history and a review of medical and therapy records relating to the presenting problem. Not complicated, it's brief. The moderate complexity level for the OT profile and the medical background and history includes an expanded review, an additional review of physical, cognitive, or psychosocial history that relates directly to the current functional performance. The high complexity code again includes the occupational profile and medical and therapy history, but it includes an extensive additional review of physical, cognitive, or psychosocial history related to current functional performance. So what is an occupational profile? The occupational profile includes client's background, context and environment that they are involved in, meaningful interests that they have, needs and their personal goals, past level and types of occupational participation. An occupational profile must be completed at the beginning of every evaluation session. Both the language in the CPT code and the framework agree on this. What is medical and therapy history? Well, it's related to the current functional performance. If it's a low complexity level, it's brief, it's problem focused, and it's limited review. There isn't much history there to affect what you're going to do with the client. If the medical and therapy history is moderately complex, it's expanded. The review of the history is related to more problems in the areas, again, of physical, cognitive, and psychosocial. With high complexity level, the medical and therapy history is extensive, and you will need to go and do an additional review to look at that history and the impact that may have on what you're going to assess and your intervention. The next series of slides will walk us through the components of the occupational therapy profile and the history, both medical and therapy, in relation to those three clinical vignettes that I presented earlier. So let's look at the low complexity level component for history and occupational profile. Let me remind you, the vignette number 1 was a 76-year-old female referred after her right distal radius fracture. She lives alone in the community. She volunteers 3 times a week. She wants to perform daily activities, especially dressing, and she has no existing or prior medical conditions related to presenting problems. So a brief history is sufficient. That is why we have chosen the low complexity level for this particular history and occupational profile. The next example is of moderate level, and this again is relating to the profile and the history. In our second vignette, moderately complex 76-year-old female, again with the right distal radius fracture, when she tripped over a friend's dog. The profile on this lady is that she lives with a partner in a retirement community, participates in social activities, wants to perform daily activities such as toileting, bathing, and dressing, and she wants to prevent another fall. She has a history of diabetes, related macular degeneration. She received prior OT services for low vision, and she has an expanded review that is necessary of her history. She is scored in the moderate level because she has more medical history impacting performance and participation limitations. She requires an expanded review, including her prior OT services for her low vision. The next example is of a high complexity level, using our third vignette, our 76-year-old female that had the fracture in the middle of the night while she was wandering. She's a long-term resident, previously mobile with a walker, toileted herself, engaged in art group, but admits to being forgetful, and she has been isolating herself. She wants to be able to toilet safely, to use her walker, and to take her art group. Again, her history had some TIAs, congestive heart failure, prior stroke, so an extensive additional review of her profile and history is required. Therefore, we would check the high complexity level component for this profile and history.
Now we move to a critical component of the evaluation descriptions in CPT, the assessment and occupational performance deficit identification. As you can see, low, moderate, and high speak to the same elements, but in low it's 1 to 3 performance deficits, moving to 3 to 5, and then in high moving to 5 or more deficits. And these deficits are relating to physical, cognitive, or psychosocial skills. But it confirms that those deficits result in activity limitations and or participation restrictions. That linkage is very important. Patient assessment. Occupational therapy best practice in patient assessment includes observing the patient performing occupations or activities, using standardized or other tests, considering the skills, factors, context, and environment that results in identification of performance deficits. This process is based on the OT practice framework, in which it suggested that in an evaluation, the therapist synthesizes information from the profile to focus on occupations and contexts. The therapist observes the client's performance during relevant activities, and the therapist selects and uses specific assessments to identify and measure contexts or environments, activity and occupational demands, client factors, and performance skills and patterns. Performance deficits is language that is unique to the CPT. They are defined in CPT as the inability to complete activities due to the lack of skills in physical, cognitive, or psychosocial categories. The therapist must identify and state the performance deficits, and the performance deficits are then to be addressed in the plan of care. It's important to note that CPT's reference to physical, cognitive, and psychosocial categories is an important validation of these areas of occupational therapy practice. Of course, you may address skills in other areas, but these are the primary words used in CPT, and their definitions, as we will see later, are fairly broad. So the questions for a therapist to ask are, what are the presenting issues of this client related to occupational performance? What assessments will need to be given, including but not limited to physical, cognitive, and psychosocial? How are these areas causing activity limitations and participation restrictions in the occupational performance areas the client wants to work on? As noted earlier, performance deficits are related to activity limitations and/or participation restrictions. You can refer to the OT Practice Framework Table 1 on occupations as a general guide. Use the general categories like ADL and IADL, as well as the specific occupations. However, occupations that are not specified in Table 1 may also be identified as performance deficits if they are appropriate to the client, and refer to or cause activity limitations and or participation restrictions. Again, performance deficits should be related to goals and outcomes. Here's the language on the 3 areas mentioned in CPT. Physical skills, referring to body structure or body function, and they list balance, mobility, strength, endurance, fine and gross motor coordination, sensation, and dexterity. In cognitive, we have a very good and significant definition of the areas that occupational therapy evaluates and addresses in terms of the ability to attend, perceive, think, understand, problem solve, mentally sequence, learn, and remember, related to the ability to organize occupational performance safely and in a timely manner. Psychosocial skills is an important component. This takes us to our roots. It refers in CPT to interpersonal interactions, habits, routines, and behaviors, active use of coping strategies, and any other environmental issues that are necessary for adaptation so that people can develop skills to successfully and appropriately participate in life and tasks and social situations. So to review, patient assessment in low complexity is problem-focused. One issue is usually brought forward. 1 to 3 deficits are identified, and these deficits affect functional performance. In moderate complexity, you move to a more detailed assessment where you identify 3 to 5 deficits, and there may be a comorbidity, but all of it affects functional performance. In high complexity, you do a comprehensive assessment, identifying 5 or more deficits. Maybe 1 or more comorbidities have an effect on functional performance. And furthermore, in the assessment, you may need to consider multiple treatment options. This next series of slides, we will look at our vignettes and show how we've identified performance deficits in the 3 vignettes. In the first, low complexity, with a right fracture. In the assessment, you observe the client performing occupations that are pertinent. You do a problem-focused assessment, which looks at range of motion, pain, strength, and how the person dresses. There are no comorbidities that are affecting the performance, and limited treatment options are considered. No modification of assessments are needed, and only 1 performance deficit is identified to be addressed in the plan of care. That is dressing. And further, you see some descriptive words that can help you in your documentation to describe the skills and elements of, that contribute to the performance deficit. Vignette number 2, it was a right fracture complicated by vision problems that caused the fracture due to tripping. So again, observing the client performing desired occupations, doing a more detailed assessment because you have to expand into pain and vision. 3 performance deficits are to be addressed: dressing, toileting and toilet hygiene, and bathing and showering. In vignette number 3, the high complexity, where the patient or client had a right fracture, but it was caused by her wandering during the night, and furthermore, it's causing some psychosocial and cognitive issues to be more pronounced. So you observe the client performing the desired occupations. You do a comprehensive assessment, which includes a broad range of issues, including cognition and social interaction. And the 5 performance deficits that are identified are in functional mobility, toilet and toilet hygiene, safety and emergency maintenance, dressing, and community social participation, including, as it's noted there, fear of falling and cognitive issues. Counting deficits is important. It will likely receive scrutiny as these new codes are used. But the important point to remember is that clinical judgment about the overall needs of the client, the expectations for this episode of care, and the overall complexity of the presenting client situation will dictate the number identified. That means clinical judgment, clinical decision-making. Use the framework list of occupations as a guide, but make the list expansive if you need to address a particular client's needs. This process, this identification of performance deficits, supports the fact that you as a therapist, as a professional, use independent reasoning and have judgment that is brought to bear on the determination of performance deficits and the development of the plan of care. So use your skills as well as common sense when you're counting performance deficits.
The next series of slides will walk through the components of clinical decision-making, again in relation to the 3 clinical vignettes that we have been using. Let's begin by looking at the components of clinical decision-making. Low complexity. Clinical decision-making of low complexity, which includes an analysis of the occupational profile, analysis of data from problem-focused assessments, and consideration of a limited number of treatment options. The patient presents with no comorbidities that affect occupational performance. The modification of tasks or assistance with assessments is not necessary to enable the completion of the evaluation component. Moderate complexity components. Clinical decision-making of moderate analytic complexity, which includes an analysis of the occupational profile, analysis of data from detailed assessments, and consideration of several treatment options. The patient may present with comorbidities that affect occupational performance. There is minimal to moderate modification of tasks or assistance, either physical or verbal, with the assessments. It's not necessary to enable completion of them. The next is the high-level complexity component. Clinical decision-making is of high analytic complexity, which includes an analysis of the patient profile, analysis of data from comprehensive assessment, and consideration of multiple treatment options. Patient must present with comorbidities that affect occupational performance, and there is a significant modification of tasks, either physical or verbal, with the assessments to enable the patient to complete the evaluation component. The next is a guide that might be helpful to some to look at the areas, in addition to occupational profile and history and assessments, that are affected by clinical decision-making. It's important to remember that clinical decision-making occurs throughout the evaluation process as clinical decisions are being made from the depth required in the profile and history to the assessment chosen and the interventions identified. This table is only meant to be a guide and help you determine what the level is that best describes the clinical decision-making component. So let's go back now again to our 3 vignettes and talk about what the complexity component is for clinical decision-making. Vignette number 1, refreshing our memory, is the 76-year-old that had a treadmill mishap, that lives alone and has no prior medical conditions. In terms of decision-making, the therapist found it to be straightforward because there were few treatment options that need to be considered, no comorbidities affecting performance, and no assessment modification. In the example of a moderate complexity level for clinical decision-making, looking at vignette number 2, remembering same diagnosis but tripped over a friend's dog, lives with her partner in a retirement community, and has the macular degeneration affecting her performance. Decision-making in this scenario is moderate because comorbidities are affecting performance. There's minimal modification or verbal cues, but there's several treatment options that could be considered. There was a detailed assessment that was given. Again, putting in the clinical decision-making about what level of assessment is needed or how many assessments are needed. The example of a high complexity level component in clinical decision-making, let's go back to vignette 3, remembering she has the same right distal radius fracture, but she fell in the middle of the night while wandering. She lives in a long-term care home, and she admits to being forgetful and has been isolating herself. In this particular decision-making, it is high because there are multiple comorbidities affecting performance. There's comprehensive assessments necessary with significant cueing and assistance, as well as safety concerns. I'll let Chris tell you now about the time involved with the new codes.
Thank you, Kathy. The new evaluation and reevaluation codes are considered service codes, just as the previous OT evaluation code was a service code, meaning it was not billed on the basis of time. These new codes are also not time-based. However, you will note in the language, the AMA has typical times associated with each of the codes. But we want to stress time is not the determining factor in selection of the code level. 1 unit of an evaluation code is submitted regardless of the amount of time spent. The complexity of the evaluation, all of the factors that Kathy went through with you, determine which level of code is selected. While a code language provides typical times, the time is not an absolute requirement. It is simply a general guideline. It is important for you to know and to be able to express to your employers and others that time cannot be used as a factor in determining levels. This is not part of the equation for determination of a level in the CPT process. Therapists must not be pressured to use time as a critical factor. What factors must be considered are those that Kathy outlined and explained and demonstrated to you. Defending appropriate levels of evaluation codes may come up in your practice. So you must remember that the components must be clearly identified and justified in the documentation. Therapists must be clear with administrators that evaluation is a process not defined by the same amount of time or level for each client, but rather by the needs and complexity of the client's individual performance deficits, activity limitations, and participation restrictions. That's why in this presentation we are stressing that you read the actual language which we've provided in one of the accompanying documents to this webinar. Arm yourself with the knowledge of the language in the actual CPT code. This will enable you to defend your choice, your clinical judgment, your determination of deficits, your review of the medical history and the conducting of the occupational profile. It is critical that you understand from your own perspective and your own reading and AOTA's interpretation what it means to choose a level in this new framework. Earlier, I spoke about payment. Unfortunately, Medicare, in its proposed rule for payment in the calendar year 2017, indicated that they will pay the amount of a moderate level evaluation for all three evaluation codes. While we are disappointed with this determination by CMS, we understand that they do not know how you therapists will be using the codes. Therefore, CMS will look at the data that will be provided on each of the bills that you submit. AOTA has met with and will continue to work with CMS to defend differing payments for the different levels of evaluation. But in the future, our arguments will be dependent on the range of codes used. So I stress again that it is an ethical and in some cases a legal responsibility to choose and report the correct code. Let me just explain the Reevaluation Code. The CPT explains the three components of the reevaluation. A reevaluation is an assessment when changes in patient functional or medical status are identified and validated. An update to the initial occupational profile is done to reflect the changes in the condition of the person, the environment, or any other factors that affect the future interventions provided during an episode of care. You must also do a revised plan of care to document the change in functional status or the significant change to the condition or any other factors which require a significant change to the plan of care. Again, a typical time is referenced, 30 minutes. Again, this is not to be construed as a limit, either a top limit or a low limit. Kathy, do you want to speak about the plan of care, please?
The plan of care identifies and pulls all the information together as part of the evaluation process. As was stated earlier in the webinar, it is the plan of care that culminates in intervention strategies and client goals. It does not have criteria attached to it, but is still a very important part of the evaluation process. I'd like to summarize here the best practice occupational therapy regarding evaluation. Chris had talked about the holistic approach, which is what we really want to do. The occupational therapy best practice is client-centered. That's why the occupational profile is so important. And thirdly, it is built on framework principles. So we all need to go back to our OT framework and look at the words and definitions to assist us to figure out the codes. Lastly, I'd like to summarize the evaluation codes and components. There, remember, are three areas: occupational profile, medical and therapy history. Secondly, patient assessment. And third, clinical decision-making. Under low complexity, in the area of the profile and medical history, there's a brief history, and it's related to the presenting problem. In the patient assessment, there's 1 to 3 performance deficits relating to physical, cognitive, psychosocial limitations, and participation restrictions. In the clinical decision-making component, it's low complexity, limited amount of treatment options, no assessment that needs modification, and there's no comorbidities. In the moderate complexity level under occupational profile and medical history, there's an expanded review of the therapy and medical records. There's also an additional review of physical, cognitive, and psychosocial performance. In the patient assessment component, there are 3 to 5 performance deficits identified relating to physical, cognitive, psychosocial limitations, and participation restrictions. In the clinical decision-making component for moderate, it's a moderate analytical complexity. It's detailed in the assessment. There's minimal to moderate modifications, and this client may have comorbidities affecting functional performance. In the third high complexity level, under occupational profile and medical and therapy history, we do an extensive review of physical, cognitive, and psychosocial performance. We've identified 5 or more performance deficits relating to physical, cognitive, and psychosocial limitations and participation restrictions. And as far as clinical decision-making goes, there's high analytic complexity. There's comprehensive assessments, multiple treatment options to choose from, and significant modifications to complete the assessment. Next, Christine will tell you about the education campaign through AOTA to help us all know and learn how to use the new evaluation codes.
Thank you very much, Kathy. We understand that this change in looking at levels of evaluation may seem daunting, that there are multiple components, that there is a change in your practice, perhaps, that may or must occur. But we need to think about how this language empowers us to promote the full scope of occupational therapy practice. The recognition in the CPT of cognitive, psychosocial, and as well as physical limitations is a tremendous move forward. The recognition of the occupational profile is a validation of our perspective that what occupational therapy's purpose is to encourage participation. All of these new concepts and new processes can, as we said, promote optimal occupational therapy practice. We encourage you to look at the language of CPT, to empower yourself, because it does reflect optimal practice and the principles of the framework. Because this new approach is a great departure from previous practice, AOTA is providing this webinar free to members. Non-members are paying a fee. AOTA will also be providing presentations at OT State Association conferences and other meetings. Look for new CE and other articles in OT practice on this new coding framework. We'll be presenting at national and specialty conferences such as the Chronic Conditions Conference in December. We will be preparing additional materials on clinical decision-making, on vignettes, on population-specific issues such as how to conduct evaluations in SNFs. Our educational campaign is focused on assuring that members accurately differentiate the levels contained in the 3 evaluation codes, and that you feel empowered to use these codes to put your practice forward, to meet your clients' needs, and to be as effective occupational therapists as you can be. We will also be developing coding resources. There are links to those key resources on the last slide, including going to the AMA website to review the actual language and other materials there regarding these new codes. I want to thank Kathy Brennan for all of her assistance and her good work in preparing this webinar. I want to thank AOTA's CE Director, Debbie Amini, for her participation and support. And we want to thank all of you for listening and assure you that we are here to answer your questions through email, on the phone, or any other way you wish to contact AOTA staff. Thank you very much for your participation. Watch for new resources on the AOTA website.
All right, very well. And AOTA would like to thank you all for viewing our webcast. To obtain your CE certificate, please proceed to the survey link. Once completed, you will receive instructions for accessing and printing your certificate.